Well, WCLC is a very important event for the whole community of physicians taking care of lung cancer patients and also other thoracic malignancies. It is also an important event because it gathers all the physicians, but in multidisciplinary aspect of the lung cancer care, surgeons, radiation oncologists, of course medical oncologists, but also patients and advocacy group of patients who play a more and more important role in this Congress. So this is a very important event in the way that it is possible to have in the same place all the community of physicians and patients around the thoracic malignancy and especially lung cancer. In this 2025 conference, we have many communications reflecting the advances made in the field of lung cancer treatment, of course in terms of targeted therapies, but also in terms of immunotherapy. And the two main communications, the two main events that are awaited during this conference are the results of the 402 study in patients with EGFR common activating mutation with the demonstration of overall survival benefit. And the second part of the second event, important event in this WCLC 2025 conference is the results of the HARMONi trial, which demonstrated that the bispecific antibody targeting both PD-1 and VEGF is able to improve the overall survival of patients with EGFR mutation and acquired resistance to osimertinib in combination with chemotherapy. So these are the two main communications during this WCLC conference, but there are so many others that it will be difficult to summarize all the communications and the advances in this field. Well, the 402 study was a randomized phase 3 study assessing the combination of chemotherapy and osimertinib versus osimertinib monotherapy in patients with advanced non-small cell lung cancer depending on EGFR common activating mutations. We already know that the combination of chemo and osimertinib was able to improve the progression-free survival of the patients, especially in patients with adverse prognostic factors like brain metastasis, detectable ctDNA at diagnosis, and also patients with a high tumor burden. But we did not know the impact of this PFS benefit on the overall survival. And during this conference, the overall survival of 402 were released, demonstrating that the combination, the addition of chemotherapy to osimertinib monotherapy will lead to a significant survival benefit with a hazard ratio around 0.75, which is a great advance in terms of overall survival. So we have now three main treatment options for the frontline treatment of patients with EGFR activating mutation. We have osimertinib monotherapy. We have the 402 regimen with the combination of chemo and osimertinib. And we have also the Mariposa regimen combining lazertinib, which is the third generation TKI, and amivantamab, which is a bispecific antibody targeting both MET and EGFR. And both FLORA2 and MARIPOSA demonstrated a survival benefit in comparison with osimertinib monotherapy. But it is at the cost of an increase in the toxicity. Of course, in the FLORA2 regimen, the toxicity of chemotherapy, which clearly can also impact the quality of life of the patients in comparison with osimertinib monotherapy, and also for the MARIPOSA regimen, the combination of amivantamab and lazertinib also led to a significant increase in toxicity, especially in skin toxicity for this combination, leading to necessitate to need a very strong prophylactic treatment for avoiding severe skin toxicity. So, of course, for the patient with EGFR mutation, this is a great hope because you can improve the survival, which was around 3 years in terms of median survival with osimertinib. You can improve this median survival of approximately 1 year, but it is at the cost of the toxicity and an increased toxicity, and probably at the cost of an impairment of the quality of life. So we have to discuss with every patient with EGFR mutation which option is the best for each patient, for every patient, according to its hope and what it expects from the treatment. Well, we know that for the patient treated with osimertinib as a single agent, the emergence of an acquired resistance is inevitable, and all the patients will experience acquired resistance. We have also some information about the mechanisms of resistance to osimertinib, but except for the MET amplification, we do not have specific treatment targeting each mechanisms of resistance, and the majority of patients are treated in an agnostic way, especially with chemotherapy. So the standard of care for patients with EGFR mutation, acquired resistance to osimertinib, was chemotherapy. There were several attempts to improve the results of chemotherapy alone, and one of the new standards of care in patients with acquired resistance to osimertinib is a combination of chemotherapy and amivantamab, with the MARIPOSA-2 study demonstrating a significant advantage in terms of PFS. But beside the amivantamab story, we have also several attempts to use immunotherapy in addition to chemotherapy in those patients with EGFR mutation and acquired resistance to osimertinib. And all the studies performed until today were negative in terms of overall survival, meaning that the addition of anti-PD-1 or anti-PD-L1 to chemotherapy did not improve the patient outcome. And this was not surprising because we know that patients with EGFR mutation are not good responders to immunotherapy. Nevertheless, we had some signal of the combination of chemo, IO and VEGF inhibitors, especially in the IMpower 150 trial, with clearly an improvement of the activity of the immunotherapy when it was used in combination with bevacizumab. In the HARMONi trial, the comparison was done between chemotherapy and chemotherapy plus ivonescimab. Ivonescimab is a bispecific antibody targeting both PD-1 and VEGF. And the fact that it was a bispecific antibody leads to increase probably the penetration of the antibody in the tumor microenvironment by the VEGF inhibition, leading to a better activity of immunotherapy in this setting. And clearly we knew that the addition of ivonescimab to chemotherapy was able to improve PFS, but now with the results released in the WCLC 2025 conference, we know that it is able to improve overall survival. And it is the first time that it was possible to improve the patient outcome, a patient with EGFR mutation with immunotherapy with this bispecific antibody. And there is a huge development program of this bispecific antibody, even in patients without EGFR mutations.